Certainly. Let's delve even deeper into acute pancreatitis, focusing on its pathophysiology, clinical features, diagnostic techniques, management protocols, long-term consequences, psychosocial implications, and advancements in research and treatment. Cellular mechanisms, autodigestion. The pancreas produces digestive enzymes like amylase, lipase, and proteases in an inactive form. In acute pancreatitis, these enzymes are activated prematurely within the pancreas, leading to tissue damage. Inflammatory response. This process triggers an inflammatory cascade involving the release of cytokines, chemokines, and leukocyte infiltration, leading to further injury and edema. Organ systems affected. Local effects. Inflammation can extend beyond the pancreas, affecting surrounding organs like the spleen, liver, and intestines. Systemic effects. Severe acute pancreatitis can lead to multi-organ failure due to systemic inflammatory response syndrome, SIRS, and sepsis. Severity classification: mild no organ failure or local complications. Moderate transient organ failure or local complications that resolve with treatment. Severe persistent organ failure such as respiratory failure or renal failure lasting longer than 48 hours. Clinical features. Symptoms at presentation: classic presentation, severe epigastric or left upper quadrant pain, often radiating to the back. Pain is typically constant and may worsen after eating. Associated symptoms: nausea and vomiting. Abdominal distension and tenderness. Fever and tachycardia indicating an inflammatory response. Physical examination findings: signs of fluid overload, JVD, ascites, and peripheral edema can be present in severe cases. Cullen's sign: periumbilical ecchymosis indicating hemorrhagic pancreatitis. Gray-Turner's sign: flank ecchymosis indicating retroperitoneal bleeding. Comprehensive diagnostic approaches: laboratory tests, biochemical markers, serum amylase and lipase. Both enzymes are elevated in acute pancreatitis, with lipase being more specific and lasting longer after the onset of symptoms. Complete blood count, CBC. Leukocytosis may indicate infection or inflammation. Liver function tests, elevated AST and ALT may suggest gallstone pancreatitis. Imaging studies: ultrasound first-line imaging to assess for gallstones, biliary obstruction and pancreatic inflammation. CT scan, contrast-enhanced CT, the gold standard for evaluating the extent of pancreatic inflammation, necrosis and complications such as abscesses or pseudocysts. Additional diagnostic procedures: endoscopic retrograde cholangiopancreatography, ERCP, used to visualize the biliary tree and remove any obstructing gallstones if indicated. Management protocols. Initial management. Fluid resuscitation. Start with isotonic fluids, such as lactated Ringer's solution, to restore intravascular volume. Monitor urine output and hemodynamic status closely. Nutritional support. Initially withhold oral intake, gradually reintroduce as tolerated, starting with clear liquids and progressing to a low-fat diet when pain subsides. Pain management: opioids may be necessary for severe pain control. Specific treatment interventions: addressing underlying causes. If gallstones are identified, perform ERCP for stone removal or consider cholecystectomy after recovery. Provide counseling and support for patients with alcohol-related pancreatitis. Monitoring for complications. Regularly assess for signs of complications such as organ failure or infection, particularly in severe cases. Complications of acute pancreatitis: local complications, pancreatic necrosis, tissue death that can become infected requiring surgical intervention. Pseudocysts, fluid collections that can develop weeks after the initial insult, may require drainage if symptomatic. Systemic complications: multi-system organ failure common in severe cases affecting the lungs, kidneys and cardiovascular system. Infection: patients are at risk for pneumonia, urinary tract infections and sepsis. Long-term management and follow-up are critical for patients with acute pancreatitis. Those who experience recurrent episodes are at risk for developing chronic pancreatitis, necessitating ongoing evaluation of pancreatic function. Adopting a low-fat diet and avoiding alcohol can help prevent recurrence. Continuous monitoring of symptoms and pancreatic enzyme levels is also important. The impact on quality of life is significant. Patients may experience anxiety and depression related to their diagnosis and the potential for complications. Involving family members and utilizing support groups can assist with emotional coping. Emerging therapies are at the forefront of research. Scientists are looking into novel biomarkers that can help predict the severity of pancreatitis and the risk of complications. Additionally, new treatment modalities are being investigated to determine the efficacy of agents that may protect pancreatic tissue from injury. Telemedicine is also gaining traction. Utilizing telehealth for follow-up care can enhance access to specialists and improve patient management, especially in remote areas. Education and awareness are vital. Community programs aim to educate the public about the risk factors for acute pancreatitis, particularly focusing on alcohol consumption and obesity. Screening and prevention efforts are equally important. Targeting high-risk groups, such as those with gallstones or heavy alcohol use, for education and preventive care can make a significant difference. Acute pancreatitis is a complex and potentially life-threatening condition that requires prompt recognition and comprehensive management. Understanding the underlying mechanisms, diagnostic methods, and treatment approaches is essential for improving patient outcomes. Ongoing research and public health initiatives are crucial for enhancing awareness, prevention, and treatment strategies. If you have specific questions or areas you would like to explore further, please let me know.